I'm Nancy Nealon. I'm the Community Program Manager for the New York, New Jersey chapter of the Parkinson's Foundation. So happy to have you with us today, and we are so grateful to welcome two wonderful expert speakers today, Dr. Roger Rossi and Jennifer Lazaro, as our expert presenters. And as I mentioned in the intro, we know that there's a ton of information to keep track of. You'll get all of this and more in a follow-up email. So take as many notes as you'd like, and we will follow up and fill in any blanks. So on the next slide, you will see information about the Parkinson's Foundation. And I'd like to just take a moment and share with you important information about what we do at the Parkinson's Foundation. And essentially that can be summed up by saying the Parkinson's Foundation makes life better for people living with Parkinson's by improving care, advancing research towards a cure. We have everything you need to live better with Parkinson's. To achieve our mission, we pursue three goals: to improve care for everyone with Parkinson's, to advance research towards a cure, and to empower and educate our global community. And we do all of this building on the energy, experience, and passion of the global Parkinson's community. We want you to know that we're here for you. There's so much you can avail yourself of. We have so many resources. Parkinson.org or our helpline. We have wonderful helpline specialists. Please call, please visit the helpline. Please visit the website. We have booklets, an Aware and Care hospitalization kit, podcasts, so many fact sheets. You can find our centers of excellence. There's so much to learn there, and I hope that you will make sure that you get to visit and check out what you can find and utilize. We also are starting a brand new process to get even more input from the Parkinson's community. So this is a new initiative meant to capture the community's perspective on various topics in Parkinson's disease, such as mental health, telehealth, or cannabis, and many other things. By signing up for this initiative, we will email you up to 4 times a year requesting that you complete a 10 to 20 minute survey. And we always report the findings back to our community. Once again, you get this link when we send it out, but we hope that you do consider participating in the PD Surveys initiative. That would be wonderful. I'm also very happy to tell you about a very special event. Hopefully some of you have perhaps participated already. NAHED does such a fabulous job for Moving Day New Jersey. This is one way that helps us to support our mission. So very excited, we're getting ready. Moving Day New Jersey will take place on Saturday, October 2nd. Hopefully you've signed up, you have a team. If not, you don't want to miss out. So go to movingdaynewjersey.org or contact NAHED at 732-639-1475. And remember, you'll get all this information too, so it's a lot to take in. We couldn't do any of this without the generous support from a number of companies. And first, I'd like to give a big shout out to our first silver sponsor. Today's program has been made possible by their incredible and generous support. So very much thanks to AbbVie for making it possible for us to have this program in place as a silver sponsor. Also, another big shout out to our friends at Adamas. Many thanks to all of you for helping us make sure that we are able to deliver these programs. Your support is greatly appreciated. Another silver sponsor is Kiowa Curran, and we want to give them a big shout out as well to all of our silver sponsors and all of our chapter supporters. Many thanks for your generous support. Next is our friends at Medtronic, and we also send our thanks and appreciation to all the great folks there as a silver sponsor. Thank you, Medtronic, for your support. And last but certainly not least, I'd also like to recognize our other silver sponsor, Synovian. Many thanks. Your support of our programming is truly appreciated. So that was a number of things to tell you about, but it doesn't tell you much about them. But there is a way that I encourage you to go and find out. And there is a link that you can go on our chapter page and learn all about the work that these companies are doing on behalf of the Parkinson's Foundation and the Parkinson's community. So visit our chapter supporters page by going to parkinson.org/NYNJ, and you'll see a tile there that you can click on that is for chapter supporters. And once again, then you'll be able to learn all about AbbVie, Adamas, Kyowa Kirin, Medtronic, and Synovium. So after a lot of information, now it's time to really get your input. And we'd like to give you a poll to take. And there's one statement missing off that, but we can make up for it. So could you tell us, we'd love to get your vote here, which statement best addresses or best describes you? So this is a poll for our audience. As you know, this is about mind, mood, and motion today. So are you a person who used to exercise back in the day? Or maybe you just don't like to exercise, but you do it anyway. Or you found some great plan that you like, or none of the above. And wow, we've got lots of votes coming in already. And I'm just going to give it another second, and then we'll tell you the results. So we have, okay, so the results. Wow, bravo, everyone. The highest vote getter here, 49%. I have finally found an exercise program that I enjoy and do consistently. I have a feeling Dr. Rossi and Jennifer are going to give you big kudos for that. So congratulations to all. Very, very well done. So at this time, we're going to flip back. We're going to move past our poll. And it's time. Let me get my poll off of my screen so I can do a better job. So at this time, I would like to invite Dr. Rossi to share his screen. And now is the time I'm going to introduce him. And I'm so honored to introduce our first speaker today, Dr. Roger Rossi, who received his medical degree from the University of Des Moines. He completed a residency in physical medicine and rehabilitation at New York University, the Rusk Institute of Rehabilitation, where he served as chief resident. Presently, he is professor of medicine and rehabilitation at the Hackensack University Medical School and at Robert Wood Johnson Medical School. He is a senior physiatrist in the Department of Physical Medicine and Rehabilitation at the JFK Johnson Rehabilitation Institute, where he serves as the director of Parkinson's disease and movement disorders program and as director of medical student education. That's a lot to do, Dr. Rossi. You must be pretty darn busy. Dr. Rossi practices lifestyle medicine, has a primary focus on improvement of function, and utilizes procedures as a means to facilitate and engage patients of all ages in exercise, proper nutrition, and social engagement, understanding their conditions, managing their pain, and improving their quality of life. Dr. Rossi values a holistic philosophy which emphasizes a thorough medical examination, medical history, performance enhancement, and functional improvement. Wow, and with that, Nahed will stop sharing my screen for my slides, and we'll invite Dr. Rossi to share his screen, and then he will proceed with the presentation. And remember, keep your questions coming in to the Q&A icon. We'll be collecting all your questions. And I'm just waiting. We're probably having some kind of technical holdup, but that's okay. We'll get it figured out as I look for my phone. Maybe someone else could give me an update verbally. Oh, there we go. We're switching. So hang on. We're getting there. Thank you for your patience with us as we switch over. Here we go. Dr. Rossi, without further ado, the floor is yours. Thank you so much. And I'll wait till make sure he is here and able to speak to you and you can see him.
Okay, can you see me?
I think you'll be getting here soon. I can hear you. There we go. Yay. All set.
Okay. Again, thank you for asking me to present today, and also to the organizers of the Parkinson's Foundation and this wonderful event and your series of Mind, Mood, and Motion. So let's start today. We have some objectives for the program. I have no disclosures. The learning objectives for today, the learners will, by the end of the program, understand the types of cognitive changes that occur in people with Parkinson's disease, understand depression, anxiety, apathy, and other mood difficulties often associated with Parkinson's disease, explore some of the recent research concerning the effects of both cognitive training and physical exercise on cognitive decline and emotional symptoms in Parkinson's disease, and identify practical strategies to improve daily functioning for people experiencing cognitive decline and provide tools to enhance participants' mental and emotional well-being. So, what is Parkinson's disease? I'm sure many of you are at different stages or awareness of the disease. We probably have caregivers as well as individuals with Parkinson's. Parkinson's disease was first described way back in 1817 by James Parkinson in the great essay on the shaking palsy. Parkinson's is the second most common neurodegenerative disease, only second to Alzheimer's. The prevalence of Parkinson increases with age, with about 1 to 2% of individuals experiencing the disease or achieving diagnosis greater than 60 years of age. And we see that almost doubles in the 80s or as one ages. So there's about 60,000 new cases diagnosed each year in the United States, and nearly 1 million Americans are affected with the disease. And if you look globally, 7 to 10 million individuals worldwide are living with Parkinson's disease. And we do anticipate that the prevalence is actually expected to increase substantially in the next 20 years due to the aging population and also the acuity in awareness of not only motor symptoms, but early diagnosis of non-motor symptoms. Males are slightly more at risk for Parkinson's with a ratio of about 1.5 to 2. It is underdiagnosed in the minority population, and along with a slight, maybe 2 to 3% increase due to genetics, there have been associated environmental or lifestyle risk factors that have been mentioned. Very commonly and foremost has been pesticides, herbicides have increased exposure. And then other things have been looked at with lifestyle to include caffeine, which may be protective. Cigarette smoking also may offer some protection. The use of anti-inflammatory, non-steroidal medications, and even gout has been looked at because, as we know, Parkinson's disease is felt to be one of the factors is linked to oxidative stress. And there have been some studies over the last few years that have linked uric acid, the component in gout, to possibly decreasing oxidative stress. So how do we make the diagnosis of Parkinson's disease? It is a clinical diagnosis, as we know, and bradykinesia, or slowness or small decreased amplitude of movements, is one of the features cardinal signs. However, this can be coupled for diagnosis with more than one of the following three cardinal signs: rigidity or muscle stiffness, tremor, usually at rest and starting on one side. So very characteristic, and by definition, Parkinson's is a unilateral presentation. If your symptoms start bilaterally, you have to look for other sources. So Parkinson's tremor as well as symptoms often start on the one side and remain more severe on the side that it started with. Imbalance and postural changes can also be presenting symptoms. There are other conditions, as we know, which are labeled Parkinsonisms because they share some of the cardinal features of Parkinson's. However, they may be unique in various other features that are unique to these syndromes. One can be drug-induced Parkinsonisms, corticobasilar syndromes, dementia of Lewy body, multiple system atrophy, PSP or progressive supranuclear palsy, and vascular Parkinsonisms. So these all can be classified as having some features of Parkinson's, but are different in their presenting features, the pathophysiology, and also the severity of the disease. Um, Motor features are often the more obvious presenting features of Parkinsonisms and Parkinson's disease. Supportive features for clinical diagnosis, as we mentioned, include unilateral onset or one side, asymmetry of the disease, again, presenting and maybe maintaining that one side affliction, responsiveness to levodopa. As we know, levodopa remains the standard in pharmacologic treatment. Levodopa was first initiated and used clinically in the 1970s. And now we are still using that as a hallmark of Parkinson's treatment. Different variations, there's extended release, continued release, different modes of application. But levodopa responsiveness is a supportive feature. So individuals that present with the disease or there's a high suggestion that they have the disease, you would think that they would respond to levodopa. If they don't have sometimes robust or even suggestive responses to levodopa, you may question the diagnosis of Parkinson's disease and may look at some of the Parkinsonisms. The clinical course, as we know, there's something called the Hone-Yar classification, but the course of the disease could last decades, and everyone is different. Premotor is an area which I alluded to earlier, which may enhance early detection. Very commonly, we have heard of one of the premotor symptoms, which is loss of smell or anosognosia. And this very commonly is affected in Parkinson's patients before they even present with motor symptoms. Sleep disorder or REM sleep behavior disorder is also very prevalent. And your patients or my patients will tell me it's not that they can't get to sleep, but they can't maintain their sleep cycle. So often they don't get into that restorative delta sleep, and they're having very disrupted sleep that affects their motor performance, it affects their bed partners, and their cognition. And constipation, although very vague and nonspecific, is often a presenting premotor symptom. So a lot of these supportive features and some of the premotor can also exist in the Parkinsonisms, but they may be more identifiable with true Parkinson's disease. Interestingly, 30% of people with Parkinson's disease never have that resting tremor. The resting tremor, as you know, is described as a pill rolling type tremor, 3 to 5 beats per second. And this presentation, like other presentations, is termed the phenotype of presentation. Often individuals that present with tremor dominant Parkinson's may actually go on to have a less indolent or severe case. But about 1/3 of patients don't present with a resting tremor. Now, we alluded to earlier non-motor symptoms, and these are very vague. They're not unique to every individual. However, every individual with Parkinson's may progress through or have numerous of these symptoms. Loss of smell, sleep disturbance or REM behavior sleep disruption, constipation to some extent, autonomic dysfunction. And what this does, there is something called the sympathetic nervous system and the parasympathetic nervous system. And the autonomic system regulates often blood pressure as well as various organ systems. So hypotension or orthostasis, those of you who have had this know the term, can result in sudden changes in your blood pressure that result in dizziness or lightheadedness. And this can be very problematic because, as we know, the resultant factor may be falls, which can be very difficult to maintain and injurious. Fatigue, Pain and sensory changes, skin changes can occur. Parkinson's disease are at increased risk for melanoma and various skin cancers. Depression and anxiety, though not affecting everyone, is a significant and often toward the end stages, the most significant and problematic feature for caregivers as well as individuals with Parkinson's, as well as apathy. Impulse control disorders are exactly that. Individuals with Parkinson's disease, sometimes when they are properly managed, or they are managed aggressively with medications to control their motor symptoms, they feel that they appreciate this on period, and sometimes they develop certain compulsions, and this is termed impulse control disorders. Cognitive changes and dementia and hallucinations and psychosis can occur during the latter stages. So the cognitive changes in Parkinson's is what we're going to talk about now, can be very significant and again, very variable in each individual. Often may start out very less severe and then progress to more severity, such as dementia. So initially it could be slowness of thought, then a group of constellation of factors termed mild cognitive impairment, and then frank dementia, which is very problematic. These cognitive changes are variable. It could be initially some changes in language. We know one feature of Parkinson's is a hypophonic or a very low vocal quality, attention and problems with working memory, problem solving, difficulty with attention to tasks, executive function, higher level tasks, especially if one is in the workforce, again, multitasking, computational assessments, problems with memory, more so short-term memory, learning new tasks, carrying over those learned processes, and visual spatial function, which is linked to cognitive changes, can be very problematic because this affects driving, this affects walking, this increases risks of fall. So these cognitive changes can be very problematic. Looking at attention and working memory, there's a little schematic I had to look at it twice too. It says, all that I'm asking is that you pay a little more attention to your surroundings. And then voila, I guess it's a pelican and he's knocked off the branch. But you have decreased attention and concentration, difficulty juggling multiple things related to memory and memory tasks. Executive function often can be affected as the cognitive and memory involvement progresses. And these are very important because then they start affecting quality of life and perception by the individual as well as caregivers and family, trouble with multitasking, problems organizing and planning, difficulty changing focus and manipulating different tasks and errands, and decreased initiation of activities that affect quality of life and activities of daily living and independence. Memory, as we are aware, we had mentioned memory is affected, and we know when we think of dementia and the number one cause of dementia being Alzheimer's disease, memory can also be affected in Parkinson's disease. And most commonly, there's decreased short-term memory. Long-term memory often does not change with Parkinson's. Language, as we mentioned, the fluency, the rate of speech, the context, as well as the patient's own awareness of speech is affected. Often you'll hear individuals say they have problems finding words or word finding difficulties or tip of the tongue phenomena. They know what they want to say, but they can't get there. Visual spatial, as we mentioned, because this very significantly can affect quality of life. And one of those gauges of quality of life is driving. And our patients that have either themselves or their caregivers or families question driving abilities really does impact independence. So cognition, and there is also Visual changes associated with Parkinson's disease can impair sense of direction. Patients may be flustered, making mistakes with driving, directions, getting lost in familiar places and surroundings, and difficulty, of course, navigating unfamiliar places, even with a navigation system. Um, and misjudging distances and locations. And here we can see as individuals are walking, are trying to position themselves in space, trying to sit in the chair, get out of a car, or as they're placing things, as you see with this cup, their perception due to visual and spatial pathology is affected, and often this leads to accidents, falls, and mishaps. Dementia is the more severe extent of cognitive limitation, and by definition, dementia is a progressive decline in thinking or behavior from a prior level of functioning in one or more of the following. And this could be memory, reasoning, physical and spoken language, visual processes, executive functions, behavior, social and interpersonal behaviors, as well as personality. And this interferes with daily life activities and social relationships. And that's what makes it the most difficult to work with and the most difficult for individuals and caregivers to deal with. 30 to 80% of individuals with Parkinson's disease will develop dementia at some point. Not meant to scare our listeners and readers, but there are interventions, and not everyone progresses to a certain severity. So, as a person with Parkinson's disease ages, or even individuals without Parkinson's disease, cognitive limitations can occur. And at risk for Parkinson's dementia are individuals with Parkinson's disease, but also normal progression of age-related changes, and even Alzheimer's can occur in a Parkinson's patient. So PD dementia, as we mentioned, often you may see impairments in attention, executive and visual spatial functions, and this in turn, the cognitive limitations further limit social interactions, memory, behavioral changes that develop, and to a severity, hallucinations. The hallucinations in Parkinson's disease are visual more than auditory. And as you can understand, as this progresses further, apathy, complete lack of interest, paranoia over physical surroundings, over family, over friends, conversation, delusions, and perceptions of individuals that are feeling already at a diminished state is enhanced by these senses of loss of self-worth and delusion, paranoia. Fluctuations in level of arousal can occur, as well as depression, further sleep disturbance, which even makes this worse because we know sleep is restorative for motor function as well as cognitive function. So if individuals are losing sleep because of these cognitive related changes, this further enhances their decline in memory. Risk factors for PD related dementia: age. As we advance in age, we're all at risk for cognitive decline. Severity of motor symptoms has been related to severity of cognitive symptoms as well. The longer disease duration is also related to the increased incidence of cognitive decline. Cognitive impairment at the very initiation of the disease has also been associated with increased cognitive impairment and worsening of PD symptoms as the disease progresses, and an akinetic rigid type presentation. Akinetic, as you know, kinesia is the study of motion. So akinesia is a lack of motion. So individuals that present with akinesia or lack of motion and rigid type postures, certain studies have shown that this has developed an increased incidence of cognitive related changes in dementia. And hallucinations. Hallucinations are a poor prognostic sign. They can present later in the disease. And as I said, visual hallucinations more than auditory, but these are also closely associated with PD-related dementia. Hallucinations, by definition, are a false or distorted sensory experience that appears real to the individual. It's generated by mind rather than by external stimuli and may be seen, heard, felt, or even smelled or tasted. So I've had patients who get up in the middle of the night because they can't sleep. They go down the stairs, which they should be doing stairs in the evening, and down to the kitchen, and they're seeing monsters in the kitchen who are there, and they really feel that this is real. So they are experiencing visual hallucinations. There's a wide spectrum, but up to 16% of people with Parkinson's disease do develop hallucinations at some point, typically later in the disease process, and often caused or made worse by PD medications. So it is very important, especially as the disease progresses, that medications have to be used very appropriately in a very focused manner, and there has to be an awareness of the efficacy of the medications along with other medications that are being used, because in concomitant use with various supplements, medications, these can definitely worsen cognitive changes. So we really want to focus on judicious use of medications. Types of hallucinations, as we said, illusions are described as mistaking a real object for something else. So you can, patients have identified family members as being a different class of individuals or caricatures. And this obviously is disturbing to the individual who may not know the difference, but can know the difference, and especially to family members. And sensory illusions, which is feeling within your space that there's someone, there's a kind of a persona and awareness, but there's simple awareness that there may be someone behind you, or sense of presence within a room. And this is amplified in individuals with sensory illusions and hallucinations. And the visual hallucinations can be as simple as flashes of light or various geometric features, or they can be very complex, as well as monsters, different objects, or different illusions of real people and individuals. That's why you've even seen some of the slides projected that, but art and creativity in Parkinson's disease, a lot of the art created by Parkinson's individuals are depictions of dreams, depictions of illusions, and they tend to be very graphic, and they are descriptive of what individuals may be thinking. So what is the treatment approach? The number one is to exclude other reasons for altered mental status and depression. And you have to, every individual with Parkinson's disease is an individual. So they are at risk for having others, and may put them more at risk for certain things, but they are at risk for having other common things that individuals as we age get, such as urinary tract infections, pneumonias, or other infections. Urinary tract infections are very common because individuals with Parkinson's disease sometimes have difficulty with swallowing. They have decreased interest in drinking. As we age, we have often possibly urinary complications. So it is important that individuals stay hydrated. Pneumonias as well. We're very in tune here at the Johnson Rehab Institute to swallowing. We have a wonderful speech department, but swallowing and attention to dysphagia, or the process of swallowing, is very important, because the end result could be pneumonia. And we do have to maintain through awareness through speech, as well as physical therapy, deep breathing, proper posture to enhance proper breathing and swallowing, and other infections. So there has to be an awareness to other things that can go on. You want to review the medications judiciously, wean those that can be adverse effect on cognition, and make sure that you're on what you need to be on, and proper dosing also. We have to ensure that Parkinson's individuals are maintaining a regimen. We have wonderful families, but not all individuals are as lucky to have a caregiver. I have individuals who live alone or and are isolated. So it may be difficult for them actually to even manipulate the medications that they're taking and the swallowing mechanics. So you do have to be aware, are patients following the program, the mode of delivery, the frequency of delivery. You want to simplify the medication regimen to balance the motor and cognitive difficulties that your patient may experience. So it is very individual. And you want to maintain a very structured and familiar environment because, as we do know, not only are cognitive symptoms as well as physical symptoms exacerbated by stress, the feeling of anxiety, stress causes decline in cognition, and this can have a very snowballing effect and affect medication management, overall feelings, depression, all of that. And individualized and very regimented daily schedules are important because routine and following routine is very successful and very important in the management of Parkinson's disease. And cognitive rehabilitation therapies, which is an evolving area within cognitive rehabilitation and the rehabilitation of cognitive and psychological disorders. Um, Medications for cognitive remediation are used. We do use acetylcholinease inhibitors, and you've heard of or seen friends and family, Aricept or Exelon are two prototypes. And these are used in general dementia as well, even non-Parkinson's dementia. NMDA, which is fancy acronym for N-methyl D-aspartase receptors. Anenda is another pharmacologic agent that is used with the goal of slowing or retarding the brain aging process and possibly increasing neuronal synaptic transmission and communication of brain cells. And we also want to treat the psychosis that may develop. And the psychosis, as we alluded to earlier, is portrayed by hallucinations and delusions. And by doing this, we reduce unnecessary medications. And there are various antipsychotics that have been used. Seroquel has been out there a longer period of time and has been used. Low doses are used to avoid worsening Parkinsonism. Lazaro also has been used. I'm using the brand names, but the trade name is there as well. But this does require blood monitoring, and that's why it may not be used as often. And over the last few years, Nuplazid has been used for Parkinson-related psychosis, and there's been some very successful results with that. Now, the area of cognitive training or cognitive remediation essentially is that we're actually training to the deficit. And cognitive training does focus on very specific tasks. It is task specific. So regular guided practices on certain standard tasks with a very focused end result or goals are essentially the foundations of cognitive function training. And this may prevent or delay cognitive impairment or dementia by increasing potential cognitive reserve. So you're actually building brain network plasticity possibilities. And this could explain some of the findings of improved clinical signs and symptoms. The brain's substance and function has also been studied with functional MRIs, and it's been shown that cognitive remediation actually has improved brain networking through neuroplasticity. Some of the challenges are thus far small numbers of people have been enrolled in some of these studies. There has not been, in a lot of studies, control groups, and there may be some placebo effect, which is fine. If you're focusing on an area, you're paying attention to that area, you're working on that area, it may not be the measure that's used, but it may be the process involved. So a placebo does have some effect. Some of the actual tools that you may use, Sudoku, crosswords, various computer-generated games, visual spatial games, we'll see in our rehabilitation gym, virtual reality, all the virtual reality measures that we're using now actually do immerse individuals in environments where they're challenged and they're using cognitive reserve to couple with physical functioning. Cognitive rehabilitation therapy also is addressed through various individualized sessions and professionals and occupational therapy and speech therapy that often work in the area of cognitive and procedural tasks with, again, a goal to address specific relevant goals for the individual that may cross over to activities of daily living. Now that brings us into the exciting area of exercise, and we do have our expert doctor of physical therapy, Jen Lazaro, who's going to speak to you. But exercise, if we look back in the 1970s when levodopa was first used, you didn't even hear anything about exercise. Exercise, they actually felt exercise may have been contraindicated in the treatment of Parkinson's disease. It really was over the last 15, 20 years or so that you really see exercise being studied. And over the last 5, 7 years, you see exponentially the attributes of exercise in all areas. So not only does exercise, as we know, improve heart and lung function through improved motor function and attention and cognitive speed, we know aerobic exercise improves attention, executive function in the cognitive domain, and memory in even healthy older individuals, but more so in individuals with some cognitive impairments such as Parkinson's disease and Alzheimer's. Memory and executive function and balance has been shown in Alzheimer's population. In the area of depression, working memory and processing speed, as well as visual learning, has also been shown to improve significantly with exercise. One study even showed that exercise was as beneficial as antidepressants in the treatment of cognitive impairment and exercise. So how does exercise actually do that in a pathophysiology, a neurological way? So exercise improves brain function in many ways. There's been preponderance of animal studies that have shown initially forced use exercise in rats has shown better functioning on cognitive tasks than in sedentary animals. There's been studies showing that actual brain health has been improved, and the brain, being an organ as well, can actually be affected by the attributes of exercise. So there's been increased growth of neurons in the hippocampus. As you remember, the hippocampus is crucial to memory, and this increase in neuronal growth in hippocampus actually does cross over to improvement in cognitive and psychological function in individuals with Parkinson's. There's been increased release of brain factors that build connections or synapses in the brain, and this increased release of synapse-forming proteins enhances connectivity in the brain, also termed neuroplasticity. And there's been increased release of brain cell growth factors, which very commonly can be depicted as kind of the steroids of the brain. And these are BDNF depicted here, or GDNF, BDNF being brain-derived neurotrophic factor, and GDNF, glial-derived neurotrophic factor. So in Parkinson's patients and studies thus far, moderate intensity aerobic exercise, 45 to 60 minutes, 3 times per week, did improve executive function. There are so many exercises and so many different findings. These are general criteria and recommendations, but as you know, the difficulties in the exercise prescription and maintenance and continuing those exercise activities. So again, various studies have shown progressive resistance exercise, 60 to 90 minutes twice a week, did improve working memory and executive function and attention. Large randomized controlled studies of high intensity or high impact, or not high impact, but high intensity treadmill exercise. In this study, 4 days per week, either to 60 to 65% or 80 to 85% maximal heart rate, did improve mobility compared to moderate intensity exercise. So we know exercise does help. We do have a feeling that high intensity as well as aerobic conditioning may have increased beneficial effect on certain neuroprotective elements. However, moving is helpful. Any movement is better than no movement, and any exercise is better than no exercise. So vigorous exercise appears to be neuroprotective and on a science-based models. People with Parkinson's disease who reported regular exercise has less cognitive decline at 1 year. But very importantly, this was also maintained after additional time. So there is a washout effect, but the sustainability is very important. And there is a beneficial effect to even historic exercise. So another counterpart to that is certain individuals may present sooner. However, historically, they may have been exercisers, and we may think that actually their high intensity exercise and their lifestyle of exercise prior to the diagnosis may have actually delayed the onset of their disease or even the severity of their disease. As we know, mood symptoms associated with Parkinson's, as we alluded to, include sadness and crying, decreased enjoyment and pleasure, decreased appetite, sleep problems, fatigue, sense of guilt or worthlessness, concentration problems, slowing and agitation, and to a severity, even suicidal thoughts. Anxiety, often associated but often apart from Parkinson's, is really the what if syndrome: generalized anxiety and worry, nervousness, tension, fear, avoidance of activities, panic, irritability, and off and on anticipatory worry. Off, as you know, and on period are described as performance measures in Parkinson's disease. Not everybody has describable or noticeable on-off periods, but those that do know what I'm speaking about. On is when you're performing well, whether it be with medications, after exercise. Off is when you feel that decline occurring. And this off can be not only physical, it can be in speech, posture, tremor, in all areas. Apathy really can be very severe, and this has to do with the motivational issues that are central to the diagnosis. And it's not only depression, but it's loss of motivation in key areas of behavior, cognition, and emotion. And it is associated with cognitive decline and PD severity. And motor symptoms are very common in more than 80%, and significant contributors to disability and stress. And disability and stress and anxiety also enhance those motor and cognitive decline. So mood symptoms don't only affect the person with Parkinson's disease or the individual by a noticeable decline in physical and cognitive functioning and self-care, quality of life, and increased healthcare costs, but they very noticeably affect family, with even physical health of family and caregivers, emotional well-being, sleep, obviously employment sacrifices that are made, as well as social connections, often isolation with friends and family. The National Parkinson's Foundation actually in their registry here that was from looking at a large population of approximately 5,000 individuals. This was a great study in 2015, found that 44% did more than 150 minutes of exercise per week. 20% did low exercise, less than 150 minutes per week, and 36% did not exercise at all. So I was happy to see that our poll that Ms. Nielsen had done prior to this did improve. So over the last 8 years, you guys have been doing much better, and I credit the individual, the family, as well as different Parkinson's Centers of Excellence, as well as Parkinson's Foundation. But you deserve the credit, and you have to understand the importance of exercise as well as what you can do to better your quality of life. So important findings are that regular exercise does equate to better quality of life, physical functioning, and less depression. 1 year later, physical activity at baseline did show that there was still improvement from exercise that was done prior to that, with improved quality of life, mobility, physical and cognitive function. And dose does matter. So I always tell my patients, you're not doing anything wrong. By the more the better. You have to enjoy what you're doing. You have to do something that's sustainable. You have to do something that you like, maybe even incorporating your partner. And exercise can be anything from aerobic to cognitive. Uh, the first, interestingly, the first exercise regimen that was described was probably 15 years ago, aerobic exercise through Argentinian tango. And so the study of dance in this Argentinian study showed a beneficial effect of exercise. And now we have different spectrum of dance through NIA, through various dance and body work. But insights into general population and general recommendations, type of exercise should be aerobic, high intensity, resistance training. However, numerous studies are looking at all kinds of exercise frequency. Often recommendations are 3 to 5 sessions per week. Session durations 45 to 60 minutes in general recommended. Intensity at least moderate, getting your heart rate up to 60 to 85% of aerobic capacity, given medical approval for that. And minimum duration of 2 to 3 months, but we encourage sustained aerobic as well as exercise practice. Why exercise for mood and Parkinson's? As we had mentioned, it reduces chronic oxidative stress and inflammation. And we know oxidative stress and inflammation have been negative impactors on the brain as well as physical functioning. It stimulates those feel-good neurotransmitters. Those exercisers out there know what I'm talking about. And now we have a new addition, the Rocksteady boxing has been used, and patients love this. And during the pandemic, even though it's been virtual, they really miss all the physical elements as well as the social, psychological elements to the Rocksteady, and the biological neuroplasticity that develops, cognitive behavioral benefits. You are going to breaking this vicious cycle by using exercise. You're empowering yourself that you do have control over the progression of your disease, and you're controlling those aspects that you're able to with possible goal-oriented tasks in mind. Best type of exercise for mood and PD, again, aerobic often is biologically helpful, but also individuals appreciate that. Dance, different body works, Tai Chi, yoga, Pilates, Qigong, strength training. Do what you love. There's something for everyone, and you really have to be able to identify what makes you thrive. And it can be a combination of things, and you can incorporate your caregivers and family members. Now, how else do we intervene? And I know our time is running short. They have a packed program, but you want to increase meaningful and social activities. And this could be reviving old activities, creating new activities, and modifying the activity that suits your needs and limitation. You want to incorporate exercise. Remember, moving is better than not moving. And problem solving for physical limitations that exist as we age normally, but more so in the individual with Parkinson's. So you want to pace activities, appropriate daily goals, maybe less rigid demands on yourself. Plan around times when your body is experiencing that off time, and work during the on times. Instead of completing long duration tasks, you may break it up. Instead of that 30-minute walk, you may do 3 times weekly. Participate in focus sessions of PT, OT, and speech as needed, and go by the guidance of your therapist who are very experienced in these activities. Anxiety management and relaxation are very helpful. Breathing activities and focused guidance, visualization, imagery are proven very helpful in regulating autonomics, anxiety, coping, worry control, sleep hygiene. Again, I can't reinforce as much. using bed for sleep only, relaxing before bedtime, keeping regular sleep hours and some type of routine, and limiting excess time in bed, daytime naps, caffeine and alcohol in the evening can further enhance sleep hygiene. Um, Thought and monitoring and restructuring your thoughts can be very helpful. You want to think positively. You want to use that cognitive remediation and cognitive therapies to rethink the big picture, capture the negative thought, however, rewind and replay and replace it with multiple techniques at positive thoughts. So these are some examples I'll go through quickly. Situation may be, doing voluntary work, and can I do that? The internal thought may be hopelessness and the emotion of negativity. But the thought that you want to experience is, I am capable of contributing, as opposed to I'm not capable of contributing and my life is meaningless. So the situation may be something that is desirable. The emotions may be depression and anxiety, and the thought may be negative, and you want to recapture that and rebottle those thoughts to positiveness. I'll skip over this one and give an example of a behavioral technique. Negative thought or reality maybe it's difficult now to get out to restaurants. Not only the masking and the distancing, but my tremor precludes me from engaging in a meal. I'm spilling things. I'm disruptive. People are looking at me. You may trial this in conjunction with your therapist, your spouse, and say, okay, let's find a time. We'll go to your restaurant of choosing. And then the outcome may be you're able to eat dinner successfully. You ordered food successfully. You may have prefaced it with bite-sized portions. You may have had a lid for your Coke. There was no spillage, and you enjoyed the evening. You got out of the house and you proved to yourself that you were able to confront an activity that you thought you were not able to. So you want to replace the negative thought with a revised positive thought, that there's accomplishment, that you're medically improving, that there's meaning in your life despite the symptoms of Parkinson's disease, and that other people, although they may be aware, people are working with you, and you're in a community and with support systems like the Parkinson's Foundation and the wonderful work that they do, your physicians and your healthcare team. You will be successful, but you do have control over your course of management. Summary: Parkinson's disease is common. It's the disease of elderly as we grow older. As far as cognitive and psychological impact, attention, short-term memory, executive and visual spatial functioning can change over time. Hallucinations and dementia can occur as PD progresses and becomes more severe. New and sudden changes should always prompt a search for infections, medication disruptions, or other medical things that are occurring. Cognitive training can improve performance on certain tasks. Exercise can improve mobility, cognition, and quality of life. And in general, 150 minutes per week of aerobic exercise may slow down progression and course of PD as well as symptom severity. However, further studies are necessary and are being done. And don't go it alone. This is a process, and you have people on your side through all the wonderful efforts that are being employed. So mood is one critical aspect of living with Parkinson's disease that you can control. Stay connected with family, friends, and caregivers. Know you're not alone in this journey, and effective treatments are available, and more effective treatments are even on the horizon. So I thank you very much for your participation. Sorry I went over a little. And I'm going to open to questions, and Nancy and the board.
Thank you so much, Dr. Rossi. Actually, we're going to give you a break, let you catch your breath. I think what's so well said at the very end, that no one needs to go through this alone, and don't do it alone. You are a great example of helping people not be alone with this. So thank you so much. You're going to come back in just a short while when we do the moderated Q&A session. Right now, we're going to switch to Jennifer Lazaro, who I am going to introduce, and she is going to come on camera here in just a moment for our chat. Let me tell you a little bit about Jennifer's credentials. after her name, many, many initials, but PT, DPT, NCS, we'll get her to tell us all about that. Jen is a physical therapist and clinical consultant in the outpatient physical therapy rehabilitation department at JFK Johnson Rehabilitation Institute, Edison, New Jersey. She's been there working with people in adult neurology across the continuum of care for 25 years. In 2011, Jen developed and implemented the LSVT Big Parkinson's program at the Institute. Once again, we'll fill you in on what that means. And she's also, in addition to all this, an adjunct instructor at both Rutgers University and South College Knoxville in their physical therapy departments. Jen received her associates in applied sciences as a physical therapy assistant in 1995. She continued on and completed her bachelor's and her doctorate from Mercy College in 2011 and her neurological clinical specialty in 2017. So once again, following Dr. Rossi here, we have so many wonderful, wonderful experts. So we're going to give our behind the scenes folks a chance to get Jen up here on camera. And then we will proceed with all those questions. And I am looking over. So Jen D, will you spotlight Jen L and myself, and we'll go from there?
You're good.
You're good? All right. It's probably just not showing up right on my camera, or on my monitor. So Jennifer, welcome. Thank you so much for being with us today. Oh, we'll get some, there we go.
Better?
How better? Yes, I can hear you. Welcome. How are you?
I'm very well. Thank you for having me today. I'm really
Absolutely.
excited to talk to everybody. I checked out the attendees list and I could see some of our boxers and in attendance. So that's nice to hear already.
Excellent. Oh yeah, I am not surprised whatsoever. And I think you probably have some other followers after this, but between you and Dr. Rossi, this is such a completely holistic approach here. You have so much experience, amazing credentials. Can you help, for the people who don't know, can you give a brief description of, for example, we use a lot of initials, LSVT Big? What does that mean?
So LSVT Big comes from the LSVT Foundation, which is Lee Silverman Voice Therapy. So you'll also know that from speech therapy as loud therapy. So they worked initially over 20 years ago on patients projecting their voices with people with Parkinson's in order to get them to be able to be heard better, communicate better. And what they did after that is started to explore how using that same intenseful motion and big efforts can correspond to the body movements as well. So the hand movements, leg movements, walking, and that's how they developed LSVT Big. So if you're familiar with it, it's a 4-day-a-week for 4-week protocol. So it's an intensive program. And as Dr. Rossi spoke already about high intensity interval training and moderate exercise, that's why the protocols were developed the way they were. So it is a very specific protocol, and they expect you also to follow up with their daily maximal exercises at least once a day following the program.
That helps maintain all the gains people have and continue.
Yes.
Rock steady boxing, many people are familiar with it, but once again, for those who think, oh my goodness, boxing can't be good. Give us an overview and dispel some of the myths about rock steady boxing.
Well, it's a very fun non-contact boxing program for people with Parkinson's. We here at JFK, we have a program that we're still running virtually. And some programs out there now are back into the gyms. But it is a development of a wellness program, so different than individualized or skilled therapy. You're in a group setting of coaches and people with Parkinson's, and you're exercising doing boxing moves and exercise moves and agility moves and incorporating cognitive function, whether that being having to remember a combination for boxing or adding other cognitive components while you're doing things to help you really focus on exercise, but also other functions through your regular life and being able to keep up with that outside of skilled PT.
Okay. So it can be fun. It's for
Love
people of all ages, I believe. Is that correct? I personally know many people in their 80s who do rock steady boxing. It's a
Oh,
real
yes.
community.
Yes. So anything
Okay.
from a young onset patient to I have boxers in their 80s, and they do a great job. And again, it's about being able to do the best that you can do for your body. So some people might be standing and boxing, some people might be standing and holding on to something, some people might be sitting and boxing, and some people might need a what we call corner man or like a boxing partner to kind of walk around with them to make sure they're safe in that group setting as well.
Okay. And I believe we're going to put a link in the chat so that people will make sure people know how to find your program as well. And you'll get that in the follow-up email. So, Jen, we just heard from Dr. Rossi about why exercise is so important for individuals living with Parkinson's disease. From your perspective as a physical therapist, as a clinician, tell us a little bit about your philosophy of why exercise is vital to living well with Parkinson's.
Well, from all the research and everything that I've seen clinically over my years of working with people with Parkinson's, I've got it in 3 words: exercise is medicine. It really needs to be dosed just like your medicine is. And it's really a part of that combination so that we can, whatever levodopa you still have available to you can be used in an efficient manner so that you can really improve and maintain quality of life over your lifespan.
That's excellent. I think that's probably a good way to remember it too. Exercise is medicine. So there's a lot of people who can be on your team for Parkinson's care, and physical therapists being a significant part. Tell us, when should someone seek out the services, and why should someone seek the services of a physical therapist?
Well, it's interesting because I'm starting to see some people come back after having had at-home orders for COVID, whether it be people who I've met before through physical therapy, people who are coming in through to our door the first time, or people that I'm reassessing through our boxing program. And what they sometimes need is a little boost of how exercise is different for people with Parkinson's than the general population, because we really do need to teach you how to use your best movements and how to maintain that best movement so that you have the best efficiency of regular everyday movements. So we talk about high intensity and effort, and it's not so that you're always working really hard so that you use up all your energy. It's so that you work really hard so that the hard things become easy. So when you find things are getting more challenging because things are just getting more difficult, that might be to the time to seek out a physical therapist. If it's more balance and gait related, an occupational therapist, if it's related to your activities of daily living or fine motor activities, or if it's related to your speech and your cognition, to your speech therapist. And we all kind of have a role to play in every part of those. And especially here, we do really work as a big team. So finding a place near you that has the availability to have all your practitioners be able to talk so that we can meet your individual goals. I said that LSVT was a protocol, but we still look at it from an individual process of everybody has individual goals, and we're going to look at those in skilled therapy. So if you find that you're falling off on how you're doing, if you find that you really are not doing what you used to because of your symptoms, or if you just feel a little bit more that you have specific goals that you want to reach, that's the time to come into therapy.
Okay, excellent. Those are great guidelines that you shared. I think it may go without saying that we are all recovering from a very, very different and difficult year without the usual opportunities to get out, socialize, move, exercise. What do you advise? How can you encourage people about getting restarted or getting started? It could be the first time for some people. It might be restarting for others, but we're promoting exercise, move, move, move. So post-COVID, hopefully we're getting close to post-COVID. How do we get started again?
Well, I would encourage you, if you feel like you have individual goals, is to seek out your healthcare provider and get yourself into therapy. It is safe to come into for services now. And, we're cleaning our hearts out and we're making sure that we're keeping you as safe as possible. So recognizing that it is a safe environment to come and exercise would probably be the first. I think that everybody that has had a diagnosis of Parkinson's should be being followed by their skilled clinicians, because we're always going to find something to help boost you up and maintain that, or improve that. It's never about maintaining. It's always, I have a couple of my patients that come in and they'd say, I know that I can't come back not having done my exercises, because I always tell them that you need to come back for something new and something better than what we did last time. In light of what's going on now, we are taking a little step back, but that's a reason to just say you need to come in. So there isn't anybody that shouldn't be feeling like they probably need a little bit of a booster session. And then in between, what you really need to do is keep up on the exercise. Exercise is medicine. And if you do that, then we can get you to the next level. And then we're going to be going up the hill rather than down the hill.
Okay. And getting, once again, that people are not alone. They don't have to do this
No.
alone.
And
go ahead.
I was going to say, if you're not comfortable getting in at first, try and start a little bit at home and see how you're feeling, because that'll give you the opportunity to know where you're at. And I would suggest, again, coming in for skilled care if you can, rather than going right to a wellness program if you kind of feel like you've slidden off a little bit.
Okay. And in conjunction with what our topic is today, and the fact that we know that disease, anxiety, depression can actually just be a part of versus a reaction to Parkinson's. Wow, that can just, once again, make it pretty tough for people to get motivated. Could you share any examples of folks who you have witnessed kind of not overcome that, but have managed to work their way through that and get to the point where exercise is part of their routine?
Usually it comes from strong care partners and strong families as well.
Okay, great point.
That's a good start. If you're trying to do this on your own, figure out where you're at and give yourself goals. If you give yourself goals and add music if you like it, add step counters are like the biggest greatest thing. And you don't even have to have one now. If you use your phone and keep it on you, which hopefully most of you are, if you go into your Apple Health settings, it'll actually tell you how many steps you're taking. And if you start there and say, gee, that's not, 2,000 steps a day is not a lot when the recommended steps are 8,000 to 10,000, then you know that's where you need to start. So starting that way and building goals and finding structure, that's why the LSVT program has been very popular, is because it provides that structure and that protocol, but it's not for everybody. And there are other forms of PD specific exercise out there if you talk to your clinician. So I would say start by seeing what your baseline is and recognizing where you were last year to where you want to go, and then create yourself goals, whether it's a chart every day. It's like I hit 2,000 steps today, tomorrow is going to be 3,000, and start to build yourself up. Add in things you like better. I grew up as a dancer. I love to dance. So maybe a little bit of dancing with your spouse in the kitchen.
Sure.
Or, if you had a sport that you used to do, even if you're not doing the full sport, even if you get out that golf club and swing it in the backyard, start to get yourself moving.
So if we think about not this big thing you have to take on, but breaking it down into smaller goals that perhaps can build upon one another. So, all right. So this concludes our far too brief, but great conversation with Jennifer. And in our remaining time, I'm going to move to the moderated Q&A session with both Dr. Rossi and Jennifer. As you can imagine, we have had many questions submitted during registration and great questions that have come in since we started. And they do cover a number of things, but I think you're both so well suited for these questions. So I wanted to start with this one. One of our registrants or viewers asks, how do you know when to stop driving? I think this is such an important question. And Dr. Rossi, perhaps we'll start with you. You're on mute at the moment, but I'm sure we can fix that and let you address it. And Jen, I'm guessing you would like to address that as well?
I probably have a tidbit or two if Dr. Rossi doesn't cover it.
Yeah, okay. All right, well, maybe we can both go, but driving really, as we talked about, depends on multiple aspects: vision, motor function, attention, and cognition. And when you are starting to individually notice some of those things, drivers with PD often make more safety errors. There's worse performance, obviously. Driving simulators after individuals have been tested have shown that there's decreased awareness, there's spatial difficulties. So when you are experiencing some apprehension, when you're experiencing some concern, when a caregiver or family member is experiencing some of those concerns with the actual task, as well as if you're able to identify that you may have, apart from the driving part, but you're starting to, say, experience some visual problems, or you know that your memory is off, and you know that the task is going to require those elements. Patients have voluntarily come and said, I realize it's not safe. However, driving is a key feature of independence, self-worth, and you have to be very careful taking that driving away. So
Absolutely.
it's an educated decision with caregivers and spouse. If there are fender benders, little accidents, those can be clues that the skill has been diminishing. But we try to preserve as best possible. And Jen and her department, occupational therapy, have very specific objective criteria. But I think individuals do deep down know that they're experiencing some suggestions of impairments that carry over to driving ability.
Okay, thank you. And Jen, do you want to follow up?
I just wanted to add that we do have here, it's one of, I think, 3 in the state, Dr. Rossi, I'm not sure, but driver training programs that unfortunately aren't covered by Medicare. But if you really want to see what your driving reactions and all of that are, we have excellent skilled occupational therapists here that can help you test driving. And she's been doing it for, I don't know, 15 years. So you would be in excellent hands here. There's also one more down the shore, and there's one in Kessler in West Orange, if that's closer to you too.
Yeah.
And like, go ahead.
I'll just add to that as well. So when in doubt, as Jen said, driver evaluation, but giving up driving is associated with increased depression, decreased mobility, activity levels, social isolation, all those things. And we do encourage, and your OTs can even get through more compensatory measures. If it's dark, don't go out. Do your activities during the daytime. If the roads are wet, if there's inclement weather, go familiar routes. Go when there's light traffic. So those are also key elements that can make a difference.
Very good. Thank you. So I'm going to switch gears a bit here and ask a question this is actually from someone when they registered, and quite popular. It comes up a lot. Does CBD work to reduce tremors, and do you recommend it? And if you could explain, in case someone doesn't know what CBD is, if you could expound on that just a little bit.
Yeah, I guess I'll start off, and if Jen has some. CBD has been used, it's an element of marijuana, and I guess it's been more in the media now because it had not been federally regulated or controlled, and there can be some obvious addictions and things, so there were always precautions. Now when there has been some medical use of marijuana, and it's been studied in a lot of different things. I think one of the first studies was a Brazilian study like in 2015 or so. And as we alluded to, we know dopamine and the dopaminergic benefit to levodopa has been helpful in a lot of motor symptoms. A lot of non-motor symptoms are not responsive to dopamine. So everything we talked about, the dementia, the depression, the anxiety, the pain, the psychosis, CBD has been used for a lot of those things in addition to sleep, appetite, as well as general well-being and quality of life. There has also been some studies that it may affect inflammatory process and decrease inflammation. So we do have patients on CBD. We as a practice don't necessarily prescribe it. You can get it online. It is important to discuss with your doctor. For tremor, I haven't seen any good study necessarily that says CBD itself has been effective in tremor. Most of the studies were open label studies. There are doing now some large control studies. But when you do understand that marijuana has some effect on mood and well-being, tremor often is accentuated by stress, anxiety, performance. And so CBD may essentially provide a calming benefit, and again, increase sleep and the restorative features of sleep. So it could indirectly have an effect on tremor reduction by alleviating stress, performance anxiety, freezing, things like that.
Excellent. Okay. Jen, a question for you. A person is interested in exercises for dropped foot and dystopia, specifically in toes. So I'm not sure if you can address that directly, but can you help the person get to where they need to go for that?
Drop foot would be that the foot's and dystonia of the foot. So you might have some clawing of the foot, or the foot is going down where your toe is catching. So again, that would be a great time to visit your local physical therapist. You can definitely do, if there's dystonia in the foot and the toes are curling, sometimes doing some self-massage, deep massage, or rolling like over a tennis ball can start to open some of that. To me, some of the dystonias in the foot can also be related to balance problems, because if you're balancing not well up here, your toes want to claw like you're a bird sitting on a limb.
Wire.
So if you think about your toes wanting to pull up, sometimes if we work a little bit on your balance, that can help mitigate it, as well as giving you individualized stretches for the foot and some other exercises. But you could start with just like kind of rolling your foot on a ball. You can also work with the same ball and put your foot on top of it, work with your toes going up, toes going down, because with the foot drop, what we want is that the heel to hit the floor as you walk, rather than your toe to hit the floor, so that your toe doesn't catch as you're coming through.
Yeah.
So you might want to work on that toes up, heels up kind of stuff, both statically, like meaning standing, or as you're walking. But I would highly recommend seeing a physical therapist to really have that examined and individual care for that.
Have it really customized for you, it sounds like. Good. Okay. Dr. Rossi, someone else is asking about some of the non-motor symptoms that are certainly very challenging. The nightmares, the fatigue, depression, skin sensitivity, and dizziness. I'm not sure in the time we have that we can do it justice, but could you maybe provide some encouragement to the person who's asking about these things, about what he or she might be able to do to help mitigate or to address this some way?
Yeah, I guess that's a loaded question, and I would go with your latter comment. I don't know if we have enough time or even a focus part of the question, but yeah, the non-motor symptoms can be just as disturbing or more than the motor symptoms. And I guess identifying the characteristic of the symptom and excluding that it's, because they are very vague, excluding that it's not the origin or the genesis is not something else. So for example, the sleep, is it Parkinson related, or is it due to other lifestyle things that can be changed, to bed partner, due to alcohol or caffeine, late in the system, the depression or the apathy, can that be addressed by counseling? Are there certain fears and anxieties that are stemming from just uncertainty or lack of education? So certain things are very organic, like the lack of smell. That may not be able to be, addressed, but there are compensatory things. So it's really kind of identifying what that non-motor symptom is, and I guess then seeking treatment. And there are different practitioners that can possibly have a different approach. So now you're speaking with a physiatrist and a physical therapist, but depending on the non-motor symptom, there are different allied practitioners. There are the realm of supplements and herbs and acupuncture and things like that that can also be used. So it's not always medicinal from a pharmacologic point of view. So I would say it depends on the condition. Um,
All right, well, thank you. I think that you did a great job addressing a pretty tough and big topic there. I want to try and fit in a couple more questions. So we have two questions that relate to vision. One person says that their eyes are terribly dry now and they don't know if it's related to Parkinson's. And another person mentions that they're having a lot of visual difficulty. Can you address that, Dr. Rossi?
yeah, we know that individuals with Parkinson do have various ocular changes that are intrinsic to the disease. There are retinal changes, there are lens changes. So it's not that it's not real. So every individual with Parkinson's really should have a comprehensive visual examination, and there can be some mitigating interventions. Some are visual exercises. Some can be adaptations to the lens, accommodations, different stigmatisms, prisms, some of those things. So they are very real changes that are intrinsic to the disease.
And this is going to be our last question that I'll be able to ask live, but let me reassure everyone, because we didn't get to every single question. I'm going to show you our helpline number again. So for anything that we didn't get to, please call our helpline. If you have other questions, call our helpline. So our last question, Dr. Rossi, and this is about anxiety. So when a doctor decides that medication is deemed appropriate for Parkinson's related anxiety, should different drugs be considered compared with general garden variety anxiety? Is there any distinction?
Well, yes and no. There are many anxiolytics out there. Some may have specific, more beneficial effects on individuals with Parkinson's. Some may produce an anticholinergic effect, which we don't want. Some may, depending on frequency, interact, or depending on the substance, may interact with some of the other medications. So some of the antidepressants, even for the secondary effects, I'm not going to mention brand names, but I may use them because, and also for anxiety, because they may actually stimulate appetite, which we know in Parkinson's patients may be depressed. They may encourage not only antidepressant effect, but improved sleep. So certain anxiolytics as well as antidepressants may promote more sedation that can be used very beneficially in the evening, as opposed to an add-on of another medication for sleep. So there are certain medications that I may use more readily in the Parkinson's population as first go-tos than in the general population for garden variety depression and anxiety.
Your description makes it so clear that our wonderful doctors who are specialists in Parkinson's and movement disorders, who understand all these really challenging and very complex situations, so important. And you can, as viewers, you can find out where those folks are located by calling our helpline for our centers of excellence. At this point, I would like to extend my deepest thanks and appreciation to Dr. Roger Rossi and Jennifer Lazaro. And we are going to let them off the hook right now and close out the program in just a moment. We just have a few more slides to show you, and they'll be up in just a second. But I'd also like to thank all of you for tuning in today, for joining us, for participating, how very important it is that we try and meet the needs of the people in the Parkinson's community. So once again, many thanks, Dr. Rossi, Jen.
Thank you.
Um,
Yeah.
for all of you who are watching right now, you are going to receive a follow-up email with a survey. Please fill out the survey. Tell us how we're doing. We really need to know, and that's the input from our global Parkinson's community. We always want to get that. And you'll also receive a link to the recording and to the resources that we mentioned. And also another thank you to our wonderful chapter supporters, AbbVie, Adamas, Kiowa Curran, Medtronic, and Synovian. If you don't know about our PD Health at Home program, please check it out. 3 days a week, Mindfulness Mondays, Wellness Wednesdays, Fitness Fridays. These are our national programs. Go to parkinson.org/PD Health to register to find out more. We'd love to have you participate. And this is the Parkinson's Foundation New York, New Jersey chapter. So I wanted to share our direct contact information. You want to know more about Moving Day New Jersey, you want to know specifically about other programs, check it out. We'd love to provide you with all this information. And then a very similar slide, but the last slide here, let me tell you again, call our helpline. The specialists who answer our helpline, they are just fabulous, 1-800-4PD-INFO. Visit our website, parkinson.org. There's so much you can avail yourself of. So we can entirely encourage you to please visit us. We wish you much safety, wellness. Thank you so much for joining us today, and we look forward to seeing you again. Thank you.